Good afternoon, everybody, and thank you for joining us for today's network call. My name is Olivia Ned, and I'm the program associate here at the National Association of Counties, and I will be filling in for Nastasia Walsh and facilitating today's network call. For those of you who this is your first contact with the initiative, this network call is part of Stepping Up, which is a national initiative to reduce the number of people with mental illnesses in jails. Stepping Up is a result of a partnership between the National Association of Counties, the Council of State Governments Justice Center, and the American Psychiatric Association Foundation, with generous support from the U.S. Department of Justice's Bureau of Justice Assistance and other private sponsors. Some quick logistics: you can use the questions box to type in questions at any time about what we are covering or if you are experiencing technical difficulties. If you are having any technical problems, we will respond to you privately to help resolve the issue. If it is a content-related question, I will read the question aloud on your behalf when we come to that part of the call. Please feel free to start submitting questions at any time, and thank you to those who already emailed in some questions from last week. I want to give a quick update on Stepping Up. I'm proud to announce that as of today, 402 counties across the country have already started to sign on to the initiative by passing resolutions to support activities to reduce the number of people with mental illnesses in jails. The most recent resolution came in from Muscogee County in Michigan with about 172,000 residents. We are excited for them to join the rest of you in this initiative. Stepping Up counties represent more than 130 million county residents in 43 states across the country, about 40% of the U.S. population. Check out stepuptogether.org for a list of all the counties who have joined the initiative. You can also get a template resolution if your county is one of those that has not yet joined the initiative. And if you do pass an initiative, please be sure to send us an email to let us know so we can include you on the map. As you know, this year, Stepping Up has launched a new series of webinars, network calls, conference workshops, peer exchanges, small group networking opportunities, and other peer learning activities for Stepping Up counties. All of the Stepping Up webinars and network calls are now archived on the Stepping Up Toolkit at www.stepuptogether.org/toolkit. The webinars and calls are organized under each of the 6 questions county leaders need to ask, the framework for the initiative. You can also download a copy of the 6 questions report on the toolkit. The next Stepping Up webinars will be hosted in January, so be sure you are signed up to receive Stepping Up email notifications. The next Stepping Up rural, mid-size, and urban county calls will be held in December. Those calls are only for county leaders who are involved in the initiative already and serve as a forum for discussion and peer networking. If your county has passed a resolution and you are not part of these discussions and would like to be, please call or email Nastasia Walsh and she will add you to the list. Her email address will be available at the end of today's call. The hope is that these calls will provide an opportunity to engage with like counties on the issues that you want to discuss the most. So I want to go ahead and introduce the speakers on the line for the call today. All of our speakers are welcome to join in on the discussion, and audience members are welcome and encouraged to direct their questions to any of the speakers from this network call or the previous webinar. From our previous webinar, we had Kim Keaton, the Associate Director of Data and Analytics for the Corporation for Supportive Housing. In this position, she works to drive and develop CSH's internal and external work using data to drive efficiency, efficacy, and impact. As part of the National Strategy and Impact team, she also leads replication and scaling of CSH's Signature Fuse initiative, which has been implemented in nearly 30 communities across the country. Welcome, Kim. We are also joined by Chrissy Canganelli from Johnson County, Iowa. Chrissy is the Executive Director of Shelter House, which offers comprehensive supportive services, 2 social enterprises, and permanent supportive housing with the intention of moving people beyond homelessness. Welcome, Chrissy. We are also joined by Dr. Regina Hicks, who is currently the Director for Harris County, Texas Mental Health Jail Diversion Program, a 5-year pilot program funded by the Texas legislature that is designed to reduce recidivism and the frequency of arrests and incarceration for people with mental illness in Harris County. Welcome, Dr. Hicks. Thank you again to all of you for being here. We know that housing is a challenging and important issue for counties as part of their stepping up efforts, and are excited to be able to continue the discussion this week with our speakers from last week's webinar. If you weren't part of last week's webinar, I strongly encourage you to review it after this call to get more details about the work that is happening in Johnson County, Harris County, and across the country to address this issue. To go ahead and kick off today's discussion, I want to ask each of our speakers one question to get their responses. Can you briefly walk us through the process for prioritizing housing in your county? Who was involved in that process? And what key stakeholders were at the table? And then how was data used as a part of this decision? Dr. Hicks, do you want to kick us off?
Sure, very happy to. Permanent supportive housing is one of our major components within our whole strategy or our whole program for mental health jail diversion. And so when we were initially planning the services that we were going to provide for this population, housing was one of those very important factors. I will credit the partners that we had from our local Corporation for Supportive Housing, as well as our two major providers for our PSH initiative, Healthcare for the Homeless Houston, as well as Search, which is another major provider for behavioral health services for individuals who are homeless. So we were able to pull together, as part of our initial program planning process, individuals from all of these organizations that helped us to kind of prioritize what we needed to do. Because of the information that I had access to in terms of understanding the correlation between homelessness and recidivism, I knew that we needed to not only provide services for people who would be eligible for our permanent supportive housing component, but also those other individuals who were literally homeless that did not meet the federal criteria. So housing was a major component, as I said, across the board, and looking at different levels and different array of housing options for people that were enrolled in our program.
Thank you, Dr. Hicks. And the same question for you, Chrissy. Can you just walk us through how your county prioritized housing and who was involved in that process and how data has been used as part of this decision?
Sure. So we're just underway with the development of the project, and how we identified or prioritized permanent supportive housing. First of all, it was the fact that we had no permanent supportive housing in our community, with the exception of a very small program offered through Shelter House that's for a very targeted population of folks with serious persistent mental illness. But it was largely through the work of the local homeless coordinating board and partnerships established there, and the realization that we had a consistent group of individuals that were chronically homeless, living on the streets of our community, and cycling through the highest cost emergency interventions possible, and just kind of a moment in time where we collectively identified this as a need and a challenge, and something that was we were not effectively addressing. It was a very anecdotal experience initially, and we determined that we would need data to be able to really define both the numbers and the scope of the challenges and issues that people were experiencing. And so it was that same local homeless coordinating board, with the addition of representatives from our local hospitals, public housing authority, police department, that then began to work to collect data with respect to the service utilization patterns and the costs incurred by individuals that were in that cohort of the homeless population.
This is Regina. I just wanted to jump in because I didn't speak to the issue of data and how we use that. We had data that we were able to collect through our jail, and that data had to do with the number of people that were in the jail that not only had a mental health diagnosis, but also were homeless. We also had the benefit of information from the Corporation from Supportive Housing, and there, as well as information that we were able to get through coordinated access. Everything being focused at that time on the way home, and looking again at the overlap between the other initiatives that were going on in the county to help people gain permanence in terms of their housing.
And Kim, can you talk a little bit about what you're seeing on the ground in terms of what is working and what is effective with the ways counties are prioritizing housing?
Sure. Well, typically, housing that comes through, like, for example, the homeless continuum of care is prioritized through a community coordinated entry system, and those who are the most vulnerable, according to typically an assessment tool, will be scored that way, and then the community of providers decides, you know, what their priority populations are in terms of prioritizing housing. There's a lot of, you know, first of all, HUD mandates that homeless systems do these coordinated entry processes, and they also state that not only should folks be prioritized based on vulnerability as assessed using an assessment tool, but that they can use utilization of crisis services such as jails and crisis health services and so on as criteria for prioritization. And so we are really starting to see communities look more to utilization as a way to prioritize folks for either specific housing programs like a FUSE program or you know, another high utilizer initiative, you know, or just in general across the system. So that utilization can take the, you know, form of matched administrative data or just eligibility based on utilization. So, you know, you can do self-report or looking at actual administrative data to see if somebody, you know, for example, is diagnosed with SMI and has extensive homeless history and extensive jail history.
Okay, so Kim, I have a follow-up question that came in. What types of data indicators are counties looking at when doing data matching for their housing and diversion programs?
That's a great question. So in HMIS is the acronym that is used to describe the homeless management information systems that HUD mandates homeless continuums of care, because it's continua of care, maintain. And these data sets typically, I mean, you know, there's data fields and structures and schema that are mandated, but typically they contain information on service utilization across a continuum. So that would be everything from street outreach contacts to stays, you know, interaction at, like, for example, a drop-in center, to stays in emergency shelters and transitional housing programs, to entry dates and move-in dates to supportive housing. And those are, you know, typically when we're looking at homeless system utilization from you know, HMIS data, you want to really pay attention to the shelter dates and the, you know, any sort of service point contacts that aren't moving into supportive housing. Hopefully, somebody moves into supportive housing or another permanent housing option, then, you know, as long as you don't see a return to service, then you know, they should likely be taken care of. But you're gonna, you know, pay attention to those indicators. You know, most of the other data is is usually self-report on, mental health and other things like that. There's an increasing trend for other systems to be entering data into HMIS or to be, doing like sort of housing assessments and that hopefully over time will build the data set. But right now, those are the real variables of interest.
Great. Thank you so much, Kim. And as we have questions rolling in, I just want to remind everybody to just go ahead and just put in your questions in the question box, and I'll be sure to read them aloud. Our next question is for Harris and Johnson County. Is there a mechanism for sharing information on your homeless populations between the hospitals? Is the jail and other key stakeholders involved? And if so, are there information sharing agreements in place, and how did you develop them? Dr. Hicks, would you like to start?
Sure. One of the things, and the overall answer to that is no. and I think that's one of the challenges that, at least for us, and I think a lot of communities, is how to get everybody to buy into information sharing. I think that right now there continues to be a lot of misinformation that people have about HIPAA and the kinds of information that can freely be shared that would at least give communities a start on some of that. We here in Harris County are very lucky that we have a pioneer, Dr. David Buck, who has the Patient Care Assistance Center, which is one that has really been in the foreground of pulling together local agreements between several providers, hospitals being one of them, the sheriff's office, and some of the other major providers, to share information on a very specific population of individuals that have been high users of services. We're in process right now through our mental health jail diversion program of setting up a database that we receive funding from the Bureau of Justice Administration that's going to help us to pull information into one system on individuals that are both being served through the behavioral health services as well as through the criminal justice system. And this will allow us to be able to enter somebody's name and be able to pull up the types of services that they're currently getting, and being able to have contact information on who it is that someone can follow up with to be able to receive those services. So we see this as being something that's really going to be very helpful for us in terms of keeping people that have mental illnesses from continuing to cycle through the jail. I'm real happy with the relationship that we've been able to have with our coordinated access system, where we do have on a routine basis, we do a match with the HMIS system for individuals that meet our eligibility criteria. And with that match, then we're able to identify folks who are currently within the jail, as well as people in the community that are coming through coordinated access that might be eligible for our program. So that's something that, as I said, has been very beneficial and really helpful. So we're still kind of developing those relationships on an individual basis, but in terms of having a county-wide agreement for some of that, we're still moving toward that.
This is Kim. I just want to jump in and say, when Dr. Hicks says coordinated access and I say coordinated entry, we're talking about the same type of system. People use different terms, but.
And the same question for you too, Chrissy. What mechanisms are you using in your county to share information on homeless populations between hospitals, the jail, and stakeholders?
Sure. So right now, all of that is under development. We have a 2-year funded grant through which an individual that actually worked on our steering committee, a police officer with the Iowa City Police Department, his position has been funded, to work with all of these entities, develop data sharing agreements, and then work with, is it Open Lattice? I can't remember which is the new name of that system.
It is Open Lattice.
Yeah, so to integrate data through that platform. So everything's under development right now. There's a lot of education that's going on, conversations, desire to participate, but nothing with the exception of the jail and police data that's been shared so far.
Great. And I have a follow-up question for you, Kim, going back to the HMIS. How can counties leverage the data that they do have through their HMIS system to develop a target population?
So I think that there are lots of ways that can be done. The way that is most effective in my mind is, and in my experience, is to do a cross-systems data match if you don't have something like that going on already with your correctional data. Frequently, what you'll see when first of all, I want to start by saying correctional jail data and HMIS data, neither are HIPAA protected. So it's a lower level, it's an easier match to execute from a security standpoint and from a legal standpoint than health data is. You can see when you do that, that there's in every community, there's going to be folks that are literally, exiting shelter, going to jail, going back into shelter, being unaccounted for a period of time, which means they're on the street or in a hospital or something else. And to really go from there, I've seen, once you put those two, for example, take everybody in the past year and what's the overlap there, and then look at their, for example, 5-year history and say, okay, 100 individuals spent, 3 months in the shelter system and some other sort of level of, and had 6 bookings and 5 bookings in each system or something like that. And you really begin to develop a pattern and a history of dependency on both systems. I think then you can take that match data and do a number of things with it. You could do the total manual approach, and you have a list, and you have, you do old-fashioned, what I call in-reach into jails and shelters, trying to identify engage actually those individuals who are often really difficult to engage and kind of have a tendency to slip through our fingers collectively as a system, as a community. You can do something a little bit more integrated, where you can take a match list and create flags within an HMIS system and within the jail system, so that when folks show up, there's a process in place that services are offered to them at a time when they're, a captive audience, so to speak. You can also, kind of go higher up the chain and really figure out how to integrate those data on a more regular basis. What Chrissy was saying about, both Chrissy and Dr. Hitz were saying about what they're doing in their communities to more fully integrate data and find out more and do things differently with people who are crossing systems is really where the field is going.
Great. So this next question is, we're going to start with Chrissy. How are you tracking progress of those individuals that are moving through your diversion and housing programs, or how do you plan to track process for those who will move through those programs?
Well, frankly, all of that is also under development. So for the Housing First, the FUSE project, we will not even break ground until March of 2018. We intend to have occupancy by this time next year. So right now, we're actually working, staff are developing those protocols and thinking through those steps and working with our partners to be prepared so that we can monitor all of that. The work that we did to analyze the pre-housing versus post-housing placement for individuals in our existing permanent supportive housing, now that we've got that information, that now is also our challenge to be able to develop a system and protocol for working with that smaller housing program as well, to continually update information as we have new people coming in with respect to their pre-housing utilization, and then while they're living with us, and for those individuals that do move out of the housing, be able to have a protocol and process in place to be able to continue to maintain contact with them. But honestly, that's a work in progress for us right now, and one of the priorities for 2018. It's a challenge when you have a small organization and you don't have funding for those types of activities, and you want to make sure that you're doing it accurately and consistently. I think that that's a real barrier for the smaller entities.
And the same question for you, Dr. Hicks. How are you tracking progress for individuals that are moving through your diversion and housing programs, or how do you plan to track progress?
Right now, we're using two standardized tools. One is the DLA 20, and the other is the FS36. DLA 20 basically is a measure that we use that helps us to track people or see their improvement around their daily living skills. And then the FS36 is one that looks at other ways of how they're improving in terms of other levels of life skills. We're also tracking booking data. Anytime someone who is enrolled in our program ends up returning back to jail, we also are tracking that level of information. Our permanent supportive housing provider is also looking at length of tenancy in terms of how long people are being able to be maintained within their current placement, and any changes that happen in terms of that. Our model, our PSH model, is also one that includes an integrated primary care and behavioral health approach. So we're also looking at changes in people's health status, knowing the number of health issues that individuals have who have been chronically homeless, and looking at how they're accessing care and improving in those areas as well.
I want to follow up, Dr. Hicks. How are you using this information that you're getting on your programs to help improve policy and practice? And if possible, can you give an example?
Give an example. Yeah, like one of the things that we learned is that through tracking some of our information is that that first 2 weeks, that first month particularly, that when people first entered into their apartment, was one that was really very crucial. And so one of the things that we had looked at and had been able to see is that sometimes there was a level of increase in terms of people kind of being in kind of crisis or whatever. And so within that, we made a commitment to have a certain amount of contact that would be happening with people during those times. And a lot of that contact was not something that we found that was just happening with the paid staff, but we were also able, through our client advisory board, identify individuals that were living in those same housing developments that were able to be willing to be a buddy to the new person that was coming in, and helping them to adjust to what it was like to be in your own apartment and some of that. So that was just one way. And some of that came from just doing focus groups with both our participants as well as the staff, in terms of what do you see as being some of the major issues that are coming up, and then taking that information and helping us to look at making appropriate changes within our policies and our program direction.
And if I may just jump in, this is Kim at CSH. As another way that communities can not only track progress but determine the effectiveness of these types of initiatives is to, for example, partner with a researcher, typically, at a local university. I've seen a lot of that. I think it's incredibly important to think long-term about how we are tracking and monitoring the success of interventions like this that could potentially really result in some cost shifts, if not just cost savings and cost shifts in our community as people more appropriately utilize services. For just as an example, in some communities, New York State being one, where supportive housing has a longer history, there have been, large-scale evaluations of the intervention that have resulted in further investments in supportive housing by non-traditional systems like the Medicaid system, like the Department of Corrections and things like that, where folks are seeing the benefits of housing and investing in it outside and above what HUD is already doing.
So it was mentioned earlier that mental health data used is mostly self-reported. Have any of you found the information that you're gathering to be reliable and valid?
Could you repeat that? Could you repeat the question? Because I'm not sure if I'm.
Yeah. So it was discussed earlier that mental health data used is sometimes, if not mostly, self-reported. Have you found the information that you're gathering to be reliable and valid?
So this is Chrissy. I'd say for the 870 people that we have coming through our shelter, we're underreporting because that is our baseline is the self-reporting content from our clients that are utilizing the shelter service. So if anything, it's underreported. But when we start looking at the lodge, the Fairweather Lodge program and the permanent supportive housing, we've established a pretty strong relationship with that person prior to their ever getting into housing, and we're working with clinicians to get an accurate diagnosis. We find that they've been inaccurately diagnosed in the past. They're certainly on medications that are oftentimes not the correct medications. So at the shelter level, I'd say it's very flawed and underreported, but by the time we're vetting people for permanent supportive housing, we have a pretty accurate picture.
This is Regina. Our program requires people to have one of the major mental health diagnoses or including PTSD. So to become eligible to get into the program, people have to have had a mental health assessment and an updated social history and all of that kind of information within the past 6 months. So I would say that our data and what we're working with on those individuals would be pretty accurate. Pulling together again an integrated service plan that not only involves addressing their behavioral health needs, but also what the other needs that they have as far as other aspects of health and human services are concerned.
Now, it was mentioned on the last webinar that something about scattered sites. And so the question is, for scattered sites that are owned by private landlords, what are some tips, tools that you're using to engage these landlords in this type of work? And what type of incentives exist to get landlords to join this type of work as well?
I can, this is Kim, and I just want to talk kind of generally. One method that, So landlords often are skittish about renting to people with criminal histories, and whether that, or not that violates fair housing law is a separate question. But one thing that service providers often find to be useful is engaging in a master lease scenario, so that they are actually leasing the main leaseholder from the landlord and are subleasing to the tenant. So are the accountable party for any damage to the property, and that's been a successful way to get landlords to rent to this population. There are other ways too, but that's one.
This is Chrissy, and for the permanent supportive housing that we offer, we own the properties. We have 3 homes, and that's our scattered site. And when we develop the 24 one-bedroom apartments, we will also own that property. So we segregate the responsibilities across staff with respect to property management versus case management, but we internally own those. With the rapid rehousing services that we offer, through which we're providing rapid rehousing for the general homeless population, and that can be as many as 400 to 500 people, so 400 to 500 people that are coming through that program. We over time have worked very hard to build relationships with individual landlords and property managers, and being able to provide the assurance that you have case management that's ongoing as people are placed in the housing will often help a reluctant landlord to work with you and rent to someone that they ordinarily may not have. And once you do establish a relationship, you find that word gets around. But it's not only being able to provide some security deposit and rent assistance, but it's also the promise of having that case management and ongoing support, and that landlord can turn to you as an organization to help facilitate difficult situations when they do, or if they do come up.
This is Jen, and I would just echo what Chrissy was just saying, and the points that Kim has made as well. One of, it's relationship. One of the things that happens at both of the apartment complex, which are managed by the same company, is having regular meetings with the apartment, the local apartment staff that happen between the permanent supportive housing staff. Again, having them knowing who it is that they can call on a regular basis if something does come up that they feel that there's a need that one of the other staff might be able to address with one of the tenants, and those have been the things. I know one of the things that we're struggling with right now because of the after effects of Hurricane Harvey is that now that there's a lot more competition for our basic housing slots because of that, with so many other people being displaced. And so one of the outcomes of that is that our current providers have been, raising the bar, if you will, on our people being accepted because they have now other opportunities to be able to rent to other populations that may not have some of the issues that our clientele does have.
So I want to kind of follow up with this other question that was also brought up on the previous webinar. For those individuals who have mental illness and more serious offenses, such as violent offenders or sex offenders, what types of housing solutions are you finding for those individuals?
This is Chrissy, and without exception, that is an underserved population.
Yeah.
Yeah. So it's catch as catch can, and that's not a good answer, but that is the answer.
Yeah. Mine is the same. Right now, within our current program, we're not even accepting sex offenders and one of the reasons was that we were told from initially that was going to be, starting with that population was going to be even more difficult. in terms of that. We have had some success with being able to get people that have had some other violent offenses to be able to be placed with the level of assurance of the support that could be there for those individuals.
And I would just echo what Chrissy and Dr. Hitz had said. You know, if the rent and subsidy portion, you know, of the program is being paid through HUD, whether it's a housing authority voucher or a COC rental support, there's going to be exclusions on sex offenders, and then on usually at a minimum methamphetamine production convictions, and then sometimes other exclusions based on, you know, the community. So it's, as Chrissy said, there's no way getting around it. It's an underserved population. I have seen communities look to serve some of those sex offenders with, you know, once they've sort of housed the first round of like an Infuse initiative, they housed everybody, and then they had funding for like 5 more, and the people left on their list that were the most difficult to house were in fact the sex offenders, and they felt like they could find rental property that wouldn't violate the terms of that person's parole, and so, or probation, and went ahead and started working with those. So theoretically, something like the Fuse model certainly works for this population. However, you're often limited by both the funding source and frankly a public relation thing too. You know, you don't want the public to see, many people don't want the public to see you're prioritizing those individuals over others. It's tough.
So this next question that came in is for you, Kim. Do you use any predictive algorithms to identify acute housing needs that may impact jail populations or have other community ramifications, such as budgets for shelters? And if so, what are some of the data points that lead to the predictions or forecasts?
That's a really good question. Thank you for asking that. I would say that the predictive algorithm for is the wave of the future for this field. And right now, what's in place in communities is a few steps behind that predictive algorithm. The assessment tools that I mentioned previously that are in use by homeless systems. I know that the main one that's probably most popular is called the VI-SADAT, Vulnerability Index Service Prioritization Decision Assistance Tool. I believe that tool has a justice involved version that's recently come out. I know that on the webinar last week, Richard Cho was talking about the housing needs tool for high-risk populations that the Justice Center had recently produced, and I think that's available on their website. So those are more like assessment tools. In terms of risk, you know, for and housing need, the indicators that come into play, particularly when folks use sort of like an algorithm-based tool based on utilization or self-reported utilization, like how likely is that person to be, like, you know, for example, the most expensive in a community. It's typically any psychiatric inpatient hospitalizations are something that really, really drives up that cost. And then emergency room use coupled with jail interaction. I mean, those are really the 3 main things.
Thank you, Kim. So we have another question, and if a county doesn't have the funding to begin a Fuse program, what are some tips or tools that you think that they can use or do in the interim until they're able to start a FUSE program? Kim, do you want to kick that question off?
Yes. There's a lot you can do. If you don't have the funding to go out tomorrow, get your highest cost, highest need folks into supportive housing and start paying for their rent subsidies, don't worry, you're just like every other community. You know, a lot of this work begins with laying the groundwork for support for an initiative like this, where you're getting folks in your community to see the community impact that inappropriate system use is having on your community. And one of the best ways to do that is like I said, to see if you can figure out how to do a cross systems data match, whether it's something super integrated and high tech, or if it's, I mean, I have seen cities really just do something in Excel and look across jail data and homeless data to see what the match was. And, you know, whichever low tech to high tech, whatever your approach is, looking at, you know, that Venn diagram and the folks in the center of the Venn diagram between your jail population and your homeless population, and, you know, beginning to tell the story of what are the interactions of these folks on the street. I think if you go back and look at the slides that Chrissy Canginelli presented on from Johnson County, they really built support based on a few case studies of folks that they followed in the community as they interacted with law enforcement on the streets, with jails, with shelters and the emergency rooms, and that sort of storytelling and groundwork can really help you know, county commissioners and, you know, people who have some control over how the money is spent to see, you know, how much this is costing and how potentially a housing intervention could be a cheaper way to go, and you can build some support from there. I do encourage you to, by the way, take a look at, I think we'll probably show a resources slide in a minute, but take a look at csh.org/FUSE. We have a lot of resources online about the FUSE initiative, so you can read about, if you're a reader person rather than a listening person like I am, you could read about some of this stuff there. We'd really love for there to be a FUSE initiative in every thought about and talked about in every Stepping Up county, all 402 of them. So I encourage you to go there.
And I could add, this is Chrissy, that for the case studies, the development of that, the information that we collected, that was, we didn't have any funding for that project. It was people building it into their, you know, their work days, and it was manually collected and managed through Excel spreadsheets. But potentially, we did, after a certain point in time, have a very small amount of funding through our local housing trust fund for a project manager to make sure that we were continuing to stay on task and moving forward. And then the Corporation for Supportive Housing also had a planning grant that we were awarded. And if the question is respect to funding for the FUSE and the housing component of it, I'd really encourage folks across the country to look at their National Housing Trust Fund dollars that were awarded to their states. That funding was to be used for people at 30% area median income and below. And that is the funding that is primarily, that grant award is primarily funding the construction of our housing. So combination between the National Housing Trust Fund and our local housing trust fund, those are pretty flexible funding sources for this type of initiative. And then HUD Continuum of Care for the supportive services and operations.
I would just add to that the relationship between your local jail or your city jail or your county jail, specifically around the whole issue of jail census, and particularly connected to jail census, the number of people who are within the jail that do have a mental health diagnosis and are also homeless. And being able to begin people just looking at that important intersection, I would say is a very good place, to begin, and then adding on into some of the other areas that were already mentioned. The Gaines Center, which is funded through SAMHSA, is one that has a lot of good information, and that's one that focuses on the intersection of criminal justice and behavioral health. And one of the cases that I've heard presenters who are connected with their talk about was this gentleman that they called $1 Million Murray, who they were able to, it goes back into what Chrissy was talking about in terms of identifying a case study that really points up the amount of money that one individual can kind of keep racking up as they are being dependent on all of these elements of pretty much emergency services, just to be able to maintain them, to be able to maintain themselves. So those would be the case study examples. And again, to really look at what's the current issue within your local area right now that is of interest and that is really pressing for people, and then being able to make those connections back to that issue, because I think that what we're talking about in terms of these intersecting populations are one that everyone has questions about and really does want to be able to address.
Thank you, Dr. Hicks. I just want to set a reminder that as we begin to wrap up this call, that if you have questions, please feel free to send them in so we can get them answered. We have another question in terms of HIPAA. What were considerations or challenges with HIPAA that you've experienced when extracting or analyzing data? And if so, how did you get the data that you needed? Dr. Hicks, would you like to take that question?
Sure, and I think Kim's earlier response was really right on in terms of that. Some of the information that you're really initially wanting to have on this population is not anything that's going to be HIPAA protected. HIPAA protected information is anything connected to someone's specific diagnosis, but you can be able to say we have this percentage of individuals that have been served in our behavioral health system. You can pull together information in an aggregate form that is not necessarily talking about one specific person or one specific individual that would then come into play as far as HIPAA is concerned. One of the things that we're already looking at within the integrated data system that I mentioned before that we're going to be developing is having levels of information that are password protected on a need-to-know basis. And what I mean by that, a law enforcement officer who just has picked somebody up on a trespass charge doesn't necessarily need to know what their diagnosis is. But what they do need to know is that this is somebody that has been seen by the local behavioral health authority. They do need to know that this is somebody right now that is also on probation with the adult probation officer, and that this is the name of their caseworker. So there's certain levels of information that can be very helpful for moving these initiatives forward that don't necessarily have to touch HIPAA in terms of that level of information.
All right, thank you so much to Dr. Hicks, Kim, and Chrissy. We appreciate all the questions that came in, and this is a very robust discussion on the importance of housing and mental illness. Thank you again for all of you on the line who participated, and to our speakers for their insights. Right now, we're going to go ahead and jump into some polling. But before that, we had about 225 people registered for this call, so we're very encouraged by the engagement from Stepping Up Counties. We'd like to know a little bit more about you before we sign off, so could we launch the first poll, please? And can we launch the second poll, please? This second question will just help us to gauge what region you're from in the country so we know who's represented on the call. And can we go ahead and launch the third poll, please? All right, great. And then can we launch poll number 4, please? Okay, great. And can we launch poll number 5? All right. All right, thank you so much for participating in this poll. The polling helps us to inform our programming and focus the technical assistance materials that we provide. And just as a reminder that if you are one of the people who did not participate or had not been able to view last week's webinar, the recording and the accompanying slides are posted at the stepuptogether.org/toolkit website. Great. Thank you so much to everyone for your participation. And please remember that we will be launching an evaluation for this call directly after the call. And if it should pop up on your screen, and we will also email it to you to get some more feedback. We want to make this network something that is useful to you as you move forward. So to close, I just want to encourage everybody to visit the Stepping Up website at www.stepuptogether.org. Here you can sign up to the initiative using the Take the Action button, and then view initiative resources on the toolkit, download the template to pass a resolution in your county if you haven't done so already, and register for future Stepping Up webinars and network calls. You can register for all future webinars and network calls at the stepuptogether.org/toolkit website. And you can also view past webinars and network calls there also. We'll also send out an announcement through the Stepping Up email list when we have our next webinar scheduled for early in 2018. The contact information for Nastasia Walsh, the Stepping Up Program Manager here at NACO, is up on the screen, as well as the contact information for the Stepping Up partners at the Council of State Governments Justice Center and the American Psychiatric Association Foundation. As always, you can reach out to us at info@stepuptogether.org, and please don't hesitate to reach out if you have any questions about the initiative. I'd like to close again by saying thank you to our speakers for taking the time to be with us today, and thank you to all of you who participated in our questions. We hope that you're on future Stepping Up network calls and webinars, and thank you again, and have a great day.